And we are back. This is Dr. DeShavo, moving into the third part of blood cell function. And once again, if you have any questions, no question is a silly question. They're all good questions. Shoot me an email. Red blood cells, I'm so tired. I say this to my primary care every time I go in to visit him. I'm so tired. And he goes, "You're a mother." I keep telling him, "Can we test me for anemia? Can we test me for blood cell diseases? What's wrong with me?" Nothing. You're a mother. I'll hear it all the, and this is true of fathers too. I heard everybody giggle out there a little bit. I think we're just tired when we're parents. But we can also be tired if we have issues with red blood cells, because red blood cells, once again, are going to carry oxygen out to our tissues so we can create lots of energy with glucose, and hopefully provide enough energy to get through the day for us. When I had my second child, he didn't sleep at all. I remember this specifically. I would eat power bars and sit and rock with him and think, okay, if I just breathe air and the glucose from the power bars go into my cells, I can make more energy because I was so tired. So anyway, we need those red blood cells to be strong and healthy to get oxygen out to the tissues. Erythropoiesis. Poiesis is the production of erythrocytes, also known as red blood cells. And this is regulated by erythropoietin from the kidneys. Seems weird, but the kidneys really need a good amount of oxygenation. They're highly metabolic, so they need to have a good, strong supply of oxygen coming to them all the time. We use a ton of energy to keep filtering our blood to get all the toxins, well, not toxins, but byproducts out. Now, you can take it as a drug, and this is especially true of people that have kidney issues. I suppose you have some sort of kidney failure, you can take erythropoietin stimulating agents to help regulate your levels of red blood cells. Some athletes will do this. It's called blood doping. And they'll take it so they get an increase in red blood cells with an increase of oxygenation. The problem with that is you get too many, you can have clots. And clots are not a good thing to have in your body because, well, on top of the clots, you have too many red blood cells. So if you get a small clot, like I spoke about before, we're always building up clots, but we break them down. If you build up a small clot, you can draw red blood cells to it if you have too many of them, and you can throw a clot. So this is not something that we want to take unless we have a medical issue. The creation of red blood cells, don't forget, will start in the bone marrow. We start with that hematopoietic stem cell that'll start to divide and go to that lymphoid and then the myeloid lineage, and the red blood cells will come from that myeloid part. Disorders typically result from a deficit or a defect in erythrocytes. So we can either have damage to the red blood cell itself or too few of them. Excuse me. So anemias. There's different anemias we're going to go over in the next few slides. One simple anemia is blood loss. If you don't have enough red blood cells and you've had a lot of blood loss, you can have anemia from that. We don't really talk about that, but that is something that can happen. So we can have a loss of red blood cells. We have a decrease in the creation of them, or the red blood cells themselves become damaged, so they cannot release or carry oxygen out to the tissues as much as we need. They all present with weakness, fatigue, pallor, syncope or lightheadedness or dizziness, dyspnea, or difficulty breathing, and tachycardia. And the tachycardia, obviously, I think the other things make sense. I don't know if tachycardia does or doesn't, but if we don't have enough oxygen going to the tissues, the heart will speed up, blood pressure will speed up to try to get more blood out to the tissues to hopefully get more oxygen out to them. Speaking of the different types of anemia, the first one that comes to mind is iron deficiency anemia. At this point, I want you to pause the tape. I've added in your supplemental media a very nice video about hemoglobin. So once you pause the tape and watch that and come back, we're going to talk a little bit about that in these tapes now. And what hemoglobin is its subunits that you'll find in red blood cells that's made from 4 proteins, and in the center of that protein we have iron. So of those 4 protein chain units. And if the hemoglobin is not abundant enough or is unhealthy, or we don't have enough iron, we can have anemias. And we'll go through all the different names and how that happens. But the first and foremost is iron deficiency. And we'll see this in people that either don't have an appropriate diet, in menstruating women because they lose so much blood, inability to absorb iron, or bleeding diseases. People can have a bluish tint to their sclera, your nails aren't going to grow properly, you have a decreased appetite, headache, irritability, stomatitis, which is ulcerations or sores in the mouth, pica or pica, I've heard some people call it. I don't know if you've heard of this or not, but this is where people have really strange urges to eat things. And I've seen weird shows about people that even eat things like ashes from cigarettes. But that is rare. I think it's more like you have a craving for something. And usually that's something that your body needs. And delayed healing. Test before you supplement. I'm a really, really strong believer in this. If you truly don't have iron deficiency anemia, you should not be supplementing with it, because we can actually deposit excess iron into our tissues. What happens with iron, if it is not on hemoglobin, if it is in our bloodstream, we actually put it into storage forms, which are ferritin, and then transferrin is what helps to absorb it from the GI tract. Free iron is very toxic to our liver. So if we don't have it in this storage form of ferritin, and we just have serum iron just floating around and we get too much of it, we over absorb into this will get all taken up. We have nowhere to put it if we already have it in the hemoglobin, and we just have this free iron. It'll deposit into the tissues of your liver and can actually lead to damaging and scarring of your liver. So you always want to test before you supplement with iron in your diet. Better yet, have foods that have high levels of iron. So diagnosis would be with a complete blood count. You could check serum ferritin and see if you're low in iron, you'll probably produce more. So that'll be looking to gather up more iron. And then transferrin absorbs it from the GI tract into the bloodstream. So once again, if the body is looking for more iron, you'll have higher levels of this transferrin. So identify, treat the cause, increase dietary intake, or you could take iron supplements. Pernicious anemia is B12 deficiency. I think a lot of people are pretty aware of this. And this is usually caused by a lack of intrinsic factor. And this is actually an autoimmune issue. People will have autoimmune response to the parietal cells that release the intrinsic factor, and those parietal cells are found in the lining of the stomach. For some reason, our immune system views them as foreign. It will go in and attack them, and they can't release intrinsic factor. And we need that intrinsic factor to absorb vitamin B12 from our diet. Now, B12 is important because it's required for DNA synthesis in cells, and that synthesis helps to mature the cells and allow them to divide. So without that B12, we're unable to do that as efficiently as we could if we did have it. The other thing that it can do is it can break down the myelin around nerves, and this causes neurological complications. Most likely they'll have numbness and tingling into their extremities bilaterally as opposed to unilaterally. Do we remember bilateral and unilateral? Bilateral means two sides. Unilateral is one side. If you have numbness and tingling down both arms, it's generally a systemic sort of problem, as opposed to a herniation would go one-sided. So always keep that in mind, one side versus both sides. But with pernicious anemia, if we truly did have B12 deficiency, we would have numbness and tingling generally into both extremities, if not all four extremities, as a neurological complication. Manifestations: bleeding gums, diarrhea, impaired sense of smell, yada, yada, yada. I think what I want you to mostly remember is, because I know that's a long line, is neurological, such as numbness and tingling. Unsteady gait is another one, and you can also have difficulty with your level of energy. So diagnosis would be serum B12 levels. That's pretty obvious, and you would have to inject B12 because it would have to bypass the stomach. So this is one of the few times that I want you to know diagnosis and treatment. Aplastic anemia is where we're actually having destruction of the bone marrow. All blood cells are affected by this, called pancytopenia. So, pan means across, cyto means cells, penia means that decrease or thinning once again. Pancytopenia. So this will be red blood cells, white blood cells, and also platelets. So this could be, I think I've heard mostly that it's medicinal causes that cause this. Could also be autoimmune, could be of no known cause, could be a virus or a genetic abnormality. Could be sudden, severe onset, possibly temporary, possibly permanent. It varies from case to case. You'll have anemia because you'll have a decrease in the production of red blood cells. You'll have recurrent infections because you're going to have too few white blood cells or leukocytopenia. And then you'll have excessive bleeding because you're not producing platelets. You'll have thrombocytopenia. So, complete blood count and bone marrow biopsy is a way to test this. Try to figure out what the cause is if you can, and treat it symptomatically beyond that if you can't figure out the cause. And we're on to our next question. There we go. Pernicious anemia is seen with patients who have a vitamin B6 deficiency due to dysfunction of the intrinsic factor. Is this true or false? Take a minute, answer that, and then we're going to move on to our next. Continue with the anemias. So hemolytic anemia, there's actually different subsets of this. And this is going to be actual destruction of erythrocytes. In a couple of these cases, they don't function as well. Could be an unknown cause. It could be autoimmune, genetics, infections. Blood transfusion reactions is a big one, or blood incompatibility in the neonate. And at this point, I have two videos that I put in your supplemental media going over, I don't know if you remember blood typing or not. Blood typing, I think, is a very important review. So go and watch that. It's a longer video, but it goes through all the blood typing, all the types, including the, A, B, and O typing, as well as the RH factor. And then I also have a video about erythroblastalis fetalis. Blastosis fetalis, sorry. That's a tongue twister. I think that's an important one for you to know, and that's why we use ROGAM. There's like I said, a great video for that. So pause the tape, watch those, and then come back. What we're going to talk about is sickle cell anemia and thalassemia, and then I do want you to know and review that video for erythroblastosis fetalis. With sickle cell anemia, I think that many people are aware of sickle cell anemia. We tend to like to go over it in these anatomy classes for some reason. Now, we're going to go over it in this class as well. This was interesting. I would not test you about this, but it is, I could see like your board's putting this on. I'm starting to think that way. It is neither recessive nor dominant genetic issue. So it is a genetic issue. It's neither recessive nor not dominant. The sickle cell trait is codominant. So if you get it from one parent, you'll express a trait of it. So, you may have one parent who doesn't, one parent who does, you'll still express it. If you get it from one parent, I have this on one of the next slides. It'll be not as expressed. If you get it from both parents, it'll be a much more aggressive form. Okay, so codominant. Once again, I won't touch you about that. That would just be an interesting board question. Hemoglobin S is what causes erythrocytes to be abnormally shaped, and they are sickle shaped. If you don't know what a sickle is, I'm going to show you a picture in a little bit, but a sickle is the curve-shaped knife that farmers use to cut through hay. Okay, it's like a crescent moon. Some of you might be too young to know what a sickle is. I'm not sure. Okay, and a sickle almost looks like a moon even. It has that kind of shape. Okay, so instead of the erythrocytes being those nice round Werther candies that we've talked about before, they get this sickle shape to them. They can carry less oxygen, and they actually can get caught on each other. Look, there's little points. They can get caught on each other, and that's not a good thing. And if the patient's not really hydrated, they can bunch together and get stuck in joints. They also just can carry less oxygen because of their shape. So you can get hypoxia and tissue ischemia beyond the areas that are blocked. Most common in people of African American and Mediterranean descent. Also seen from South and Central America. I think for the most part, this is really affiliated with people that are African American, so that's what I would focus on for you. Forms of sickle cell, you can have the sickle cell trait, which is heterozygous. This means you didn't get the trait from one side, one parent. You got the trait from another, so it's heterozygous. You've got one, I don't want to say normal, but you have one normal and one sickle cell. This will mean that less than half your erythrocytes are sickled. So you'll have the sickle cell trait. You'll have fewer and less intense attacks, per se. Sickle cell disease is when you get it from both parents. So this will be homozygous. That means that you have the same of both. This is the most severe form. Almost all of the erythrocytes are sickled or sickle shape. Typically, this will appear around 4 months of age with a sickle cell crisis. It's a very painful episode. You can get, these sickle cells can block blood vessels. You can cause tissue damage. It can cause death of tissue beyond the blockage. They can get trapped around joints and cause joint pain. It can be triggered by dehydration, stress, high altitudes, because your body will start creating more red blood cells. When you go to high altitudes, you don't have as much oxygen. Your kidneys sense that, release more erythropoietin, you create more red blood cells, so you have more oxygen. And athletes will actually go to high altitudes to train to get more red blood cells. So then when they come down to sea level or just above sea level, they have more red blood cells and they have more oxygen in their tissues. So, little side note there. And fever with the sickle cell crisis. Sorry, I got a little off track there. So, diagnosis, you would test their blood. Once again, I would not ask you about this. And life expectancy is improving with better treatment. I've heard the treatment's just gotten better and better with this. There's not truly a cure, but there's medicines that help to keep it under control. Oxygen therapy helps with low oxygen. Hydration, I think, is one of the huge treatments for it. Pain management, obviously. Infection control, vaccinations. Blood transfusions to try to get normal red blood cell shapes back into their system. Marrow transplants, try to get normal formed red blood cells. And genetic counseling to prevent it. So here's some complications. Once again, if I test you, I'll do it from the notes, but sometimes it's helpful to have these to review and look at it in a different way. Thalassemia is another genetic issue that we have with the creation of hemoglobin itself in the red blood cells. There's abnormal hemoglobin that is either on one or two chains of those 4 change units, and they don't make the proper type of hemoglobin, so they can't carry oxygen as well. And once again, this is genetic. And this is predominantly in people of Mediterranean descent. Others as well, what I would focus on if I were to ask you would be Mediterranean descent, because I see that being the most common one. They can have all sorts of side effects from this: delayed growth and development, fatigue, dyspnea, heart failure, hepatomegaly, splenomegaly, bone deformities, and jaundice. You know, I would stick with those anemic signs primarily with this. Severe cases can lead to death in childhood depending on how aggressive the damage is to the hemoglobin chains. So life expectancy can improve with effective management. Complete blood count and iron levels would be a good way to diagnose this. Chelation therapy, blood transfusion, and taking out the spleen are treatments for this. But once again, we're not going to get much into the treatments unless I specifically go over it. So let's practice. Let's take a little breather here and practice. This is going to be a little hard, but that's okay. We are up for the challenge. When we're talking about these anemias, I want you to take a peek. And what do you think? This is a tough one. This one could be out of the ones that we just went over. I want you to pause the tape. I keep saying tape. I should say video. Iron deficiency. This is a little tough, I know. But with iron deficiency, the red blood cells actually start to look paler, which is kind of interesting. Yeah, everybody's like, I know what this one is. I know what this one is. This is a red blood cell. And pause the tape if you don't want to hear this. That has sickled. Has that sickle shape, sickle cell anemia. Now, this one is a little difficult, and I actually stole this one from offline. What do you think this might be? Any guesses? This is normal. This is abnormal. Okay, this is anemic blood cells. And this is going to be specifically pernicious anemia. And what happens with pernicious anemia is you actually have red blood cells that are larger and malformed from the normal blood cells. I'm not sure if I was really specific about that previously. So, but in pernicious anemia, you're going to get megaloblastic red blood cells that are slightly normal or larger than normal and abnormally shaped. All right, so move that back up. Well, I'll get that later. We're going to move into polycythemia. Let's finish this out. So polycythemia is probably something that you have heard of before, where you have abnormally high erythrocytes or red blood cells. This is rare. I had a patient who had this, and he actually was on blood thinners to help prevent any clotting or any culmination of those red blood cells. And he was actually on triple the dose of warfarin. Every time he went to get it, his doctor would have to call to confirm. But for some reason, he just had thick blood. Most often we'll see polycythemia with some sort of cancerous disease or neoplastic disease. And it simply increases blood volume and viscosity, which can lead to clotting, and the red blood cells can actually block off blood vessels, which will lead to tissue ischemia and necrosis. And you can throw thrombi or clots. You can have hypertension, heart failure, hemorrhage, damage to the spleen, damage to the liver. And this can actually be seen in AML, or acute myeloblastic leukemia. So, once again, I wouldn't ask you this on this slide, and most of the manifestations will make sense because they're going to be a byproduct of thick blood, clotting blood, and blood that doesn't allow oxygen to get to the tissues that needs to get to. And that, my friends, brings us to platelet disorders, which I'm going to finish in the next video. As always, if you have any questions, shoot me an email. I'd be happy to answer them. Thank you. See you in the next video.